So in this communication, the focus is really on telemedicine and remote healthcare, and also to assess whether there may be some research and academic opportunities despite the current crisis. Well, it's probably fair to say that we've not been the greatest adopters of telemedicine and remote care in vascular surgery or venous disease in general. But all of the consultations that we're performing at the moment are via telephone or video conference, and actually with a detailed history and a photograph of the leg, or even a look at the leg via a video conference, most of us can make a reasonably good diagnosis. And certainly this can be used to inform and reassure the patient, and also offer advice about compression and exercise and other conservative measures. Clearly, this is not a substitute for in-person evaluation and assessment, but I think there's a lot that we can do to try and triage and reassure patients remotely.
Obviously, if this is the only form of interaction with the clinician, it makes it quite difficult. Because seeing how a patient actually reacts to the questioning and what they can actually show you in terms of often of physical signs are very important. However, a lot of primary assessments could undoubtedly be done over telehealth, and a decision made as to what form of investigation strategy should be offered, rather than necessarily offering all patients a blanket duplex scan if they are referred up with varicose veins. It also allows a better form of relationship potentially with those people in primary care who are looking after people with a leg ulcer, that actually you could develop a very easy system of a communication between you, the patient, and the frontline person in primary care using something like Microsoft Teams or Zoom, that you could actually all have a three-way consultation to decide on the best management for a particular patient. I have no doubt that once the COVID crisis is over, we will all reflect on whether we should go back to our old ways of always seeing a patient in person, rather than actually having some form of telehealth system where you can communicate with the patient and actually be able to see any signs that they actually have. If you were to look from the patient's point of view, it will undoubtedly be a much quicker way of getting a specialist opinion. It will undoubtedly save time with respect to having to attend a clinic or a hospital to get an appointment, and potentially allow more patients to be treated, to at least have an opinion in a shorter period of time.
The one part of the practice that has suffered is pelvic congestion. That is a difficult consult online. It needs her to be there with a chaperone. There's a lot of ice to be broken. It's not easy to talk about painful sexual intercourse online. So it's a bit of an issue. And you do find that they would rather suffer than come in, but because that's what they've been doing for donkey's years, for 50 years. Everyone's told them that PCS either doesn't exist or is no big deal, and women should just live with it. But as we've broken the ice and we've done a lot of public talks and GP forums and things, but those are the patients who are even difficult to follow up because they don't like to come online with it. The other part of the venous practice that has suffered, which is very, very understandable, is venous erectile dysfunction. You can imagine there is a world of venous erectile dysfunction that occurs in younger men, and because of venous leaks, it's related to varicocele and as well. And that group is not talking. They're not talking online because they are an even harder ice to break. They already jump over all sorts of psychological hurdles to see somebody.
COVID-19 has changed our world and flipped it upside down. As physicians, we're trying to do our best to modify our care to best care for our patients with venous ulcers. In our center at Ohio Health, most of the venous ulcer care is being delivered by virtual health. We're trying to keep our patients out of the hospitals to decrease their risk for infections related and complications related to COVID-19. As we all know, most of our patients with venous ulcers actually have significant other comorbidities, which places them at risk for complications from COVID-19. So what we have done here is to modify compression wraps so that the patients can apply their own compression wraps.
What is clear is the COVID-19 crisis across the world has pushed us all into developing remote monitoring and telephone clinics in a much more rapid fashion than perhaps we had anticipated. And the, I guess, a silver lining on the cloud has been just how well received this has been by a number of patients, and is certainly something we need to continue doing. From a remote care telemedicine option for venous patients in particular, we at least have the opportunity to monitor symptoms and look for deterioration. It's quite clear that most venous problems can be put on a monitoring phase, and even patients with leg ulcers can be stabilized in bandages during COVID with a view to treating these patients on when the crisis passes. Telemedicine or app-based surveillance will enable us to at least monitor the wounds, look for progression, bring patients in who deteriorate into an emergency setting to escalate their treatment if necessary. Obviously, from a leg ulcer point of view, it's good to see the wounds, and this can be done either by video monitoring or, of course, patients uploading images to app-based or email-based systems. And this is something we've instituted in our hospital, which is proving very helpful in monitoring patients.
This is a very good question, because it is, with most elective venous procedures having been cancelled, there will be a large number of patients with C2S, C3 and C4 disease that will not be referred to a specialist for further assessment. Not knowing how healthcare services will actually return to normal and over what period we will be required not to perform any form of elective interventions and only be offering urgent interventions, we do not know. Therefore, this raises the interesting prospect that we may actually be able to look at the progression of venous disease by taking a large cohort of patients and seeing what evolves over a year. It also means that it gives us an opportunity to evaluate more conservative forms of treatment, such as the use of compression hosiery in the C2, C3 group, to see actually if there is any proven benefit for its usage. It is something that I'm very interested in, and that we are trying to obtain funding to see if this is something that we could do on a national basis. So yes, I think it is quite important. I think the other area that will be of interesting is that the majority of people have stopped doing venous thrombolysis during the COVID crisis, and it will actually give us an opportunity to collect another cohort of patients who have not been having venous thrombolysis, to establish more the natural history, to see how the post-thrombotic syndrome develops, and see whether these patients in the future, when they become chronic, will be suitable for iliac vein intervention if their symptoms require it. So it is important to think that there are various opportunities to look at the natural history of not only superficial, but also of deep venous pathology.
Yes, it is an opportunity to study the natural history, but we really have to not do interventions for 5 or 7 years. I'm sincerely hoping COVID doesn't last that long and shuts us all down for 5 or 7 years. But will we actually see manifestations within the next few months, even in acute iliofemoral DVT? Because we run a teleconsulting service, we have a fairly active telemedicine service in our clinic. So we are prescribing medications for patients in Manila and Jakarta and Cambodia and stuff. We have an online consent-mediated, medication service which delivers where they are. So we can manage these patients with the old traditional approach of anticoagulation, etc., especially with the new oral anticoagulants. But how long for are we going to do nothing? To be able to study the natural history, I don't know. So I don't see this as an opportunity, because at least from Singapore's point of view, we anticipate that in about 3 months or so, we will start opening up. And in about 6 months, we will be fine. Or at least in terms of being available to provide intervention will be okay. Whether the interventions come in or not is a different story.
We can spot a severe COVID from a minor one, but we're not very good at predicting which so-called minor ones might become severe. And once they become severe, which ones may survive with ITU and which ones really shouldn't go to ITU because they're going to do badly. So we very badly need better prognostic indicators that we can use at the very beginning, so that we can focus the aggressive treatments on the patients who may benefit and not overtreat people who really have no chance of survival. And many of those prognostic indicators may turn out to be thrombotic markers or markers of inflammation and thrombosis that we as vascular specialists are relatively familiar with. So that's one huge area of important and very urgent research. Another area would be better treatment of the severe cases. It's quite clear that many of the people who die because either because they thrombose the microvasculature in their lungs or because they've had major pulmonary emboli. Clearly, better, more effective anticoagulation or even lysis may help those patients. That's another big area of clinical research. And then once they've, and then the other area I've already alluded to is for the survivors after they go home, they are probably at much higher thromboembolic risk for quite a long time than they would otherwise have been. So we need to optimize our anti-DVT prophylaxis for that group.